Good morning, friends. Today, we have a webinar on venous thrombosis at rare sites. And our speaker is Dr. Paolo Bucciarelli. It's from Milano, Italy. This webinar is brought to you by Mumbai Hematology Group. It is supported by INTAS and managed by Mice Ideas. I thank Dr. Manoj Kumar and his team from INTAS, Mr. Rajesh and their team from Mice Ideas, Executive Committee of Mumbai Hematology Group, our chief guest of the day, Dr. Avatar Krishna Ganju from Nagpur, our guest speaker of the day, Dr. Paolo Bucciarelli from Milano, Italy, all our discussants who are themselves eminent hematologists, new participants for sparing your Sunday morning. To introduce you to the agenda of next weekend, Saturday, 9th April, 7 o'clock. We have Dr. Wang from University of Buffalo, USA, speaking to us on acute myeloblastic leukemia, optimizing the treatment goals and the role of MRD. Next Sunday morning at 11:30 a.m., we have the speaker from Belgium, Dr. Dan, and he's going to speak to us on post-transplant lymphoproliferative disorders, something on which he has worked for 30 years. Our discussants today, we have once again a very good number of very important personalities from all across the country. We have Dr. Priyanka Samal, Professor and Head Department of Clinical Hematology from IMS and SIM Hospital, Bhubaneswar. We have Dr. Akanksha Garg, Associate Professor, Department of Medical Oncology from GCRI, Ahmedabad. Dr. Shilpa Bhartia, Consultant Hematologist from Parkview Super Specialty Hospital, Apollo Hospital, Kolkata. Dr. Shilpa Prabhu from Majumdar Shah Medical Center, Narayan Hridayalaya, NH Health City, Bangalore. Dr. Radhika KK from Nizam's, Hyderabad. Dr. Shweta Lankad from Avinash Cancer Clinic, Pune. Dr. Aniket Mohite from Jahangir Hospital, Pune. Dr. Tejaswini Gudibande from Narayan Health, Bengaluru. Dr. Kunal Goyal from Institute of Hematology and Transfusion Medicine, Medical College and Hospital, Kolkata. Dr. Gunjan Prasad from Apollo Hospital, Kolkata. Dr. Akshay Mandloi from TMC, Kolkata. Dr. Rima Abraham from AIMS, New Delhi. And now I'm privileged to introduce the guest speaker of the day. Guest speaker today is none other than Dr. Avatar K. Ganju. All of you know him. Whoever has anything to do with hematology, he's a prominent personality for the last 30 years. He's Senior Consultant Head, Hematology, Hemato-Oncology and Bone Marrow Transplant at American Oncology Institute, Nagpur. He's ex-Senior Consultant, Clinical Hematology at Central India Institute of Medical Sciences, Nagpur. He's ex-Senior Consultant, MKP Salve Institute of Medical Science and Lata Mangeshkar Hospital, Nagpur. He was international guest speaker at Philippines Society of Hematology and Blood Transfusion 10 years ago. He's been invited as a guest speaker at multiple occasions in various conferences, both in India and abroad. His hematology training was from the Department of Clinical Hematology, Sher-e-Kashmir Institute of Medical Sciences, Srinagar, JNK. This was followed by a fellowship in hematology and hemato-oncology at University of Wisconsin. In 1990, he had to move to Nagpur from Kashmir due to militancy. He's a member of ISHBT, IACA, ASH, and EHA. As of today, he has over 35 years of practice in the field of hematology and hemato-oncology. It's my privilege to invite him to inaugurate our webinar and give us some words of wisdom. Thank you.
Dr. Ganju, please unmute yourself.
Thanks, Professor M.B. Agarwal, for this warm and generous introduction. It's an honor and privilege to be the chief guest of Mumbai Hematology Group for today's program, which is being conducted by you as the president of MHG. About Professor M.B. Agarwal, sir, I remember that it was in mid-80s during his 1 week long classes at Sion Hospital, I got inspired to take up hematology as my career. I was at Sher-e-Kashmir Institute of Medical Sciences when a couple of times I met him, and then more often after I left Kashmir in January 1990 when I relocated myself in Nagpur. Professor M.B. Agarwal guided and encouraged me during those difficult times. Professor M.B. Agarwal sir's effort for the spread of hematology in India and this part of the world have been phenomenal. He has been getting those astute researchers, teachers, doctors, the very fountainheads who have a great name in the discoveries of some aspects of hematology and have given guidelines and algorithms to manage diseases. These lectures are classroom teachings from different parts of this planet, from their offices or hospitals, and heard in the comforts of our drawing or bedrooms or even the places where one is moving. It's like the ancient and hidden wisdom of Vedas and Upanishads being brought from Himalayas into the cities by the contemporary saints and sages of the modern world. And now, to all my younger colleagues who are at the crossroads of their career, I will recommend some of them to pursue hematology. Hematology is no more at gross level, but is better understood at molecular level. The researchers in this field are discovering, understanding, and expounding the very basics of life, already existent proteins, pathways, and their drivers, and how life works at cellular and subtle level. It seems to be beyond comprehension, yet the human endeavor goes on. And this is possible because of the very existence of possibility to know. Thus, the knowing occurs through the augmentation of these sense organs by the sophisticated varieties of equipments which one is using. Therefore, I feel the science of hematology is interesting and fulfilling because it takes you to the glamour of hematologic diagnosis in labs with clear-cut distinction of subsets, and also to the treatment of patients at the bedside armed with conventional drugs, target drugs, bone marrow transplantation, and presently genetically engineered immune cells to treat diseases which were incurable so far. It's indeed a science which humbles you and takes you to the roots. The time has also come when every day a huge volume of knowledge is getting manifest and is being used in the care of mankind, that it is extremely difficult to keep pace with this knowledge. Hence, we should start thinking of pursuing a branch in hematology, like specializing in malignant hematology, benign hematology, and so forth and so on. And now, few advices. We have been consumers all along, consuming the resources in the society. Once, as hematologists, we have started working for the society, we should cease to be a consumer and start contributing and be a contributor. We should contribute our services to the society, city, nation, and maybe even at the global platform. Contribution means maturity. Contributor means one is mature enough in terms of human development. We have a great role to play in the large scheme of things, where we, the blessed ones, are supposed to play as a contributor at some period in life. Now, it is time to thank once again Professor M.B. Agarwal and MHG for giving this privilege and opportunity. Sir, I appreciate you as a contributor and your immense contribution to the society at all the levels. Now, with this, I have a pleasure to inaugurate this meeting in which Professor Paolo Bucciarelli, an eminent hematologist, is going to discuss venous thrombosis at rare sites. I wish the meeting, as usual, a grand success. Thank you, sir. Thank you.
Thank you, Dr. Ganju, for that very well-crafted speech. It was very, very inspiring, beautifully worded, and thanks for the words which you used for me as a person. Thank you very, very much for sparing your valuable time this morning. We'll move on to the second part of this morning, and I'll again share my screen. We have now our Sunday quiz for the postgraduate students. So this is a relatively simple quiz today. You look at this picture. And the question is, what is likely to be the diagnosis when different percentage of people develop bleeding at different sites? And the percentages are given over here, the highest at the bottom, the lowest at the top. And you have to forward your answer, the name of the disease or diseases, to mbagarwal1@gmail.com. I'll keep this picture on for a while. You can have a look at the picture, think which bleeding disorder this may be, and answer that name or names by email to this email ID at the top. As usual, the winner will be fastest finger first. However, we will announce names of all those who send in the correct entry from India or from anywhere in the globe. So send your answer by email to mbagarwal1@gmail.com. Winner will be the fastest finger first. Time to move on to our weekly case profile. And this case has been called a deep sea dive. Not the CSEA, but a capital C, the deep sea dive. We had a 23-year-old Nigerian male who was admitted with acute cholecystitis with secondary to cholelithiasis. Examination shows that the brain tip was functional. There was nothing significant in the past or family history, and there was nothing to clinically think of sickle cell disease. Pre-op workup showed his hemoglobin was 11, the MC was a bit low, the MCH was a bit low, and the MCHC was a bit high. The reticulocyte count was modestly raised. The bilirubin was increased, and the indirect fraction was the main fraction. At this stage, the surgical unit referred this patient for hematological opinion as a hemolytic anemia was suspected. This is what his peripheral blood film showed. What is conspicuous are obviously the target cells, which are present in large number, occasional spherical cells over here, and this particular cell, which shows a crystal-like structure. And over here, you can see a large number of target cells, polychromasia, and those crystals of the red cells. And over here, you see the spherocytes, which is marked, the spherocytes and the spherocytes. You see the target cells, which are again marked by different type of arrow, target cells all around. And then you see this crystal. And you see this cell, which looks peculiar. I mean, other way I would have called it maybe a partially sickled cell. This was a case of hemoglobin C disease. In hemoglobin C homozygous, you see target cells, you can see occasional spherocytes, and you see these classical crystals which are not seen in any other hemoglobinopathy. Heterozygous carrier of hemoglobin C, that is hemoglobin C trait, are asymptomatic and have a normal hemogram, while the homozygous have a relatively mild hemolytic disease and there is mild splenomegaly. One of the serious complications is they can develop significant retinopathy. These are some of the pictures from the literature. This is fluorescent angiogram of the eye showing several leaking sun fans. And these are some colored picture of the same, showing once again leaking C fans. In terms of geographical distribution, hemoglobin C disease has highest prevalence in the West Africa. It's a beta chain variant, and therefore you may have cases of double heterozygosity, hemoglobin S with C, hemoglobin C with thalassemia, beta thalassemia, and hemoglobin C with other beta chain variants, and they all have been described. Hemoglobin SC double heterozygosity produces various manifestations of sickle cell disease. Hemoglobin C in India is a curiosity. With the single-digit cases published in the literature over last 40 years from India, and majority of these are hemoglobin C carrier state. And as I mentioned, the total number published is less than 10. This is a book picture of cellulose acetate electrophoresis showing you that hemoglobin C is virtually at the site of application. This is A, this is fetal, this is sickle, and this is C. And this C overlaps with hemoglobin A2, hemoglobin E, and hemoglobin O Arab. In India, this site with a significant hemoglobin would be invariably considered as hemoglobin E, as both C and O Arab are rarity, and hemoglobin A2 will never be in this quantity. There is an interesting test described in the literature called crystallization test. I showed you the hemoglobin crystal. So this simple test is you take 2 drops of the whole blood and add 3% sodium chloride solution, incubate it at 37 degrees or even at room temperature for 3 hours. And then look under the microscope and you will see the characteristic large crystals if the patient has homozygous hemoglobin C or SC disease. This crystal formation can be utilized in underprivileged countries to distinguish these from homozygous sickle cell disease. It is suggested that the crystallization test is very important even to differentiate C from O Arab and E, and that can be done in India. This is HPLC biored variant, again a book picture showing you where the hemoglobin C features. This is A2, this is C, and this is reasonably away from hemoglobin S, F, and A. So this was the case of a deep sea dive. And now we come to the main part of our today's webinar, the guest lecture. And the lecture, as was mentioned, is on venous thrombosis at rare sites. And the speaker is Dr. Paolo Bucciarelli from Italy. It's my privilege to introduce him. He runs an ambulatory anticoagulant clinic and is in charge of it at A. Bianchi Bonomi Hemophilia and Thrombosis Center at Polyclinic, Milano, Italy. He's a part of the staff of the thrombosis outpatient clinic at that center, which cares for both hemophilia and thrombosis. He's also involved in the clinical research in the field of both thrombosis and hemostasis. Since last 4 years, he's responsible for the anticoagulant clinic at that hospital. Given his expertise in epidemiology and statistics, he's involved in the study design and statistical analysis of studies dealing with risk factors for thrombosis, particularly venous thromboembolism and the rare coagulation disorders. He has interest in predictive models for venous thrombosis and coagulation disorders and in network analysis. He's a reviewer for several journals in the field of hematology, especially hemostasis and thrombosis. Since last decade, he is the official methodological reviewer for the Journal of Thrombosis and Hemostasis, which is the official journal of ISTH. Almost 30 years, he has published over 130 papers in peer-reviewed journals and participated to several national international congresses in the field of hemostasis and thrombosis as guest speaker or chair. I am privileged to have him as the speaker for the Mumbai Hematology Group. And so we have over 14 to 15 countries, delegates who have logged in today to listen to you. And I'm sure that the practice of thrombosis, venous at rare site will be changed after your lecture today. So over to you, sir.
Thank you very much, Professor Agarwal, and good morning to everybody. It's a privilege for me to be a host of your meeting, and the topic of today is venous thrombosis at rare sites. So, may I share the screen? Okay. 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 Can you see the slides?
Yes.
Okay. So the topic is venous thrombosis at the rest size. I will talk about 3 types of rare thrombosis at sites different than the lower limb vein, which is the most common site of venous thrombosis. And these are cerebral sinuses and vein thrombosis, splenic vein thrombosis, which can subdivide into portal, splenic, mesenteric, and suprahepatic, and upper limb vein thrombosis. For each of these sites, I will talk about the natural history of the disease, risk factors and pathogenesis, and treatment. So let's start with the cerebral sinus venous thrombosis. Here is shown a picture with our veins in our head and neck. As you can see, the most common site of cerebral vein thrombosis is the superior sagittal sinus, followed by the transverse sinus, and less frequently the straight sinus and the jugular veins. In about 2/3 of patients, more than one sinus is involved, most commonly sagittal sinus and transverse sinus. The incidence was increased in the last years. In very old study, it was about 3 to 4 cases per million adults per year. More recent data, they describe an incidence of 13 to 16 cases per million adults per year. This increase is not due to a worsen of disease during the last year, but mainly to more accuracy of diagnosis, particularly higher accuracy of objective instruments for diagnosis of this disease, and higher attention paid by doctors for this disease. About risk factors, we can divide them into local risk factors, which are mainly brain tumors, infectious, particularly sinusitis and automastoiditis, and trauma of the head and neck. About systemic risk factors, the most common are oral contraceptives and pregnancy, that explain why, for the first episode of cerebral vein thrombosis, female sex is much more represented than male sex, particularly women at a reproductive age. Then we have thrombophilia, both acquired and inherited, and systemic cancer. Here are the presenting symptoms. As you can see, the commonest symptom at presentation is headache. Headache is quite specific, and that's why in some cases the diagnosis can delay several days. And maybe patients present at the first step of the hospital when headache is increasing and is not responsible to painkillers, and is followed by other typical symptoms like motor deficit, like seizures, both focal or generalized, or symptoms characterized by intracranial hypertension as visual loss and papilledema. These are particularly important. Diplopia, papilledema, and visual loss as typical symptoms related to intracranial hypertension, which is a quite scary complication of this disease. Here you can see the some typical presentation of basic CT scan. Sometimes you have hemorrhages, focal hemorrhages that are due to infarction due to stop the vessel wall. And this is the prognosis. As you can see, most cases, if the disease is recognized and treated appropriately, we have a complete recovery of the disease. About 80% of patients completely recover, and at the end of the acute phase, they have a ranking scale very low, 0 to 1. In some rare cases, the disease we can have a residual dependency, or in very rare cases, death, when the disease is very, very severe. But in most of cases, this is completely recovered. Which is the recurrence rate? Here I show 3 studies. One is from our group, which is one of the largest single center studies, including 145 patients. And one is the meta-analysis by Dentali, and the first one is a registry coordinated by Jose Ferro, which is a leading expert in this disease. We can see that the rate of recurrence is quite low. It accounts for 2 to 3% of recurrence in cerebral vein thrombosis, and 3 to 7% if you include also other kind of thrombosis. Which are the individuals with a higher risk of recurrence? Men have a 9-fold increased risk of recurrence than women. Why this? This is because for the first episode, women are more represented. If we leave out the 2 most common risk factors, oral contraceptives and future pregnancy, are treated with prophylaxis against thrombosis, these 2 main risk factors disappear. And that's why for recurrence, men have a 9-fold increased risk than women. Another setting of patient who can have a higher risk of recurrence is patient with high or severe thrombophilia defects, particularly antithrombin or homozygous states for factor V11 prothrombin mutation, double heterozygotes on individuals with antiphospholipid antibodies. We have a 5-fold increased risk of recurrent deep vein thrombosis. Or people with myeloproliferative neoplasm, like polycythemia and thrombocythemia, which can be complicated by this rare disease as cerebral vein thrombosis. Mild thrombophilia usually is not associated with an increased risk of recurrent CVT. As other episode of venous thrombosis, also cerebral vein thrombosis is a multifactorial disease, which means that it can be caused by the association of genetic, transient, acquired, mixed risk factors. As you can see here, it shows that the 2 most common risk factors for the first episode, the 2 most common transient risk factors are oral contraceptives and pregnancy per period, as I said before. And this is common by all studies. Concerning inherited thrombophilia, you can see that the most severe defects, antithrombin, protein C, or proteinase deficiency, which are very rare in the general population, account by about 5% of cases in cerebral vein thrombosis, for a 6-fold increased risk by these defects. While the milder risk factor, factor V11 and prothrombin mutation, account by about 5-fold increased risk for factor V11 and 10-fold increased risk for prothrombin mutation. Hyperhomocystinemia, which is another mild risk factor and can be considered mixed because it's caused by both genetic mutation in the pathway of homocysteine and by vitamin deficiency, accounts by about for about 27% of cases of CVT for a fourfold increased risk. As you can see, I said before that thrombosis is often caused by the interaction of acquired and inherited risk factors. Here you can see clearly that when in women oral contraceptive use is associated with one or more of inherited deficiency of genetic defects like factor V Leiden and prothrombin mutation, the risk of cerebral vein thrombosis is increasingly sharpened by from 18-fold for hyperhomocystinemia, 30-fold for factor V Leiden, and almost 80-fold for prothrombin mutation, indicating that there is a synergistic effect between inherited and acquired risk factors. This is one common polymorphism, MTHFR. This is quite often used as a thrombophilia defect, as in the thrombophilic workup. But as you can see, this is not a real risk factor for thrombosis. So it should never be part of a thrombophilia workup. It should never be searched for cerebral vein thrombosis and for other kind of thrombosis. So it should not be included in the thrombophilia workup. On the contrary, JAK2 mutation, which is a known marker of myeloproliferative neoplasm, can be one risk factor for cerebral vein thrombosis, because this kind of disease can be the first clinical manifestation of a myeloproliferative neoplasm. In this paper that we published about 10 years ago, we showed that some patients who experience this kind of rare venous thrombosis were positive for the JAK2 mutation some years before that they experienced a symptomatic myeloproliferative neoplasm. So this kind of mutation should be part of the thrombophilia workup in patients with cerebral vein thrombosis. And for the same reason, also the search for PNH clone should be included in the thrombophilia workup, because PNH accounts for about is a life-threatening disease and is a very high risk factor for thrombosis, accounting for about 50 to 60% of death in PNH patients. And as the thrombosis can include both common sites like lower limb or pulmonary embolism, but also rare sites like intra-abdominal and cerebral veins. So also the search for PNH should be part of the thrombophilia workup in these patients. What about treatment? Treatment can be subdivided into treatment of the acute phase with antithrombotic agents, but also etiologic treatment. So if the CVT is caused by infections, for instance, so we should do as much as possible to treat these infections and leave out this potential mechanism of thrombosis. There is also treatment of intracranial hypertension, which is very important to treat this very important and severe complication. And we can also treat patients with symptomatic, like painkiller for headache and anti-epileptic drugs if the patient presents with seizures. I will focus only in this presentation on antithrombotic treatment, which can be divided into acute phase with heparin and thrombolytic agents, and chronic phase for the secondary prevention of recurrent thrombosis. Concerning acute phase, we spend I spent a few words for the use of thrombolytic agents. There are very few studies talking about the use of these agents. This is all the systematic review, including 72 studies for a total of 169 patients. In most cases, there were case reports or case series. There are no randomized control trials for the use of this agent. And you can see this, the use of thrombolytic agents is complicated by a consistent number of intracranial or extracranial hemorrhages. The mortality in this acute phase is about 5%, with 7% of patients concluding with dependency. In this newer systematic review, including 15 studies, again with no randomized control trials, about 156 patients were included. In most cases, the thrombolytic agent was used as a local thrombolysis, and only in 2 studies as systemic thrombolysis. As you can see, the percentage of intracranial hemorrhages is lower than in the previous systematic review, but the case fatality rate, which is the rate of patients died for this complication, is very, very high, accounting for about more than 58% death due to intracranial hemorrhage. That's why the treatment with thrombolytic agents in this disease is still an experimental treatment and should be confined only in patients with severe condition, diffuse brain edema, bilateral thrombosis, or patients who worsen despite an appropriate medical treatment. So very, very rare situations. Concerning treatment with anticoagulants, heparin is the drug of choice in most cases. And as you can see in this Cochrane database of systematic reviews, including 2 randomized controlled trials in which heparin was used in the acute phase of the disease, there is a clear benefit of this drug in terms of reduction of death or death and dependency. Heparin gave a 70% reduction of death and dependency in the acute phase. So it should be the treatment of choice. At the variance of thrombolytic therapy, there is a very low risk of systemic hemorrhage, and such hemorrhages do not influence the outcome. So there is not an increase of dependency or mortality due to hemorrhages. So even in condition where the disease presents with some focal intracranial hemorrhages due to infarction, which is a secondary complication of thrombosis, we should treat this patient. So the focal hemorrhages should not be a condition that delay the treatment. We can make some exception, for instance, when the hemorrhages are very large. In this case, I can suggest to use low-dose heparin or half-dose heparin in the very early phase of the treatment, and then follow the patient with subsequent CT scan. And if you see that hemorrhage doesn't worsen, you can use therapeutical dosages of heparin, which is very important to treat this patient as soon as possible. Concerning the secondary prevention of thrombosis, which is the treatment that is used to avoid recurrences, This is mainly due also now with vitamin K antagonists. But there is some evidence that also DOACs, direct oral anticoagulants, may have a role in this setting. How long do we have to treat patients with oral anticoagulants? It depends on the cause of cerebral vein thrombosis. If cerebral vein thrombosis is related to a transient risk factors, for instance, pregnancy puerperium, oral contraceptives, which is the two most common transient risk factors, which is no longer present at the end of the treatment, we can stop treatment after 3 to 6 months because we are confident that the rate of recurrence is very low. We can extend the treatment up to 12 months in the presence of mild thrombophilia, or in the case maybe we have not obtained a complete recanalization after the first 3 to 6 months. In most rare cases of patients with severe thrombophilia, by severe I mean deficiencies of antithrombin, protein seroproteinase, homozygous states of factor V Leiden or prothrombin mutation, or double heterozygosity, or patients with myeloproliferated neoplasm, JAK2 positive, or patient with recurrence of past venous thrombosis episode, or in case of men with idiopathic first episode of CVT, because men, as you can see, is are a type of patient that recur more often than women, we can decide to prolong, to extend the treatment lifelong. But these are a very low percentage of patients. In most cases, the treatment will stop after the first 6 to 12 months. The treatment with VKA is done with the classical INR of 2 to 3, which is the common range that used for all types of venous thrombosis. I said before that there is some space also for DOACs. There are no very large clinical trials with these drugs. There is one small clinical trial using dabigatran, which gave some positive results. And this is the Action CVT is a recently published large multi-center international studies, which included more than 1,000 patients for whom doctors decided to use either warfarin or DOACs. And the decision was led to the they freely decided to use either warfarin or DOACs. And as you can see, even if it's not a randomized control study, it's not a rigorous study, but you can see that we have some positive results in terms of efficacy, because DOACs have the same efficacy than warfarin in terms of recurrent thrombosis, death, and recanalization. And it seems that DOACs are safer than warfarin in terms of major hemorrhages. 70% lower reduction of hemorrhage with DOACs than with warfarin. As you can see also by these Kaplan-Meier curves, same efficacy and lower risk of hemorrhages. So they can be a promising kind of treatment that can substitute warfarin or anti-vitamin K antagonist, especially if we decide to use anticoagulation lifelong. So let's move now to the second group of splenic vein, of rare site of venous thrombosis, which is the splenic vein thrombosis. Splenic means thrombosis in one or more of the venous in the abdomen, portal, splenic, mesenteric, or suprahepatic. We can divide splenic vein thrombosis into two main groups. The first is extrahepatic portal vein obstruction, and the second is Budd-Chiari syndrome, which involves the suprahepatic veins. The first extrahepatic vein obstruction is more frequent in Western countries, whereas Budd-Chiari syndrome is more frequent in Asian countries. Concerning extrahepatic portal vein obstructions, it is the obstruction of single portal veins, or can be it can involve also other sites like splenic and superior mesenteric. In this case, we talk about portal, splenic, mesenteric veins. It can lead to portal hypertension, and in the chronic phase, portal vein is replaced by a so-called cavernoma. After cirrhosis, extrahepatic vein obstruction is the commonest cause of portal hypertension. Its incidence is about 10 cases for 100,000 patients per year in Western countries. And it's also present, even in rare condition, also in children, which is the cause of the major cause of gastrointestinal bleeding in children. So in case of children who present with this this picture, this clinical picture, we should suspect EHPO. It can be diagnosed in the acute phase or in a chronic stage. These are the symptoms most commonly present in the acute phase. Abdominal pain is the commonest symptoms. Abdominal pain is a very unspecific symptom, and that's why some patients delay the diagnosis. In these cases, the diagnosis is made when the disease is already chronic. In few cases, the abdominal pain is accompanied by ascites of fever. When the disease involves other veins apart the portal vein, the first symptoms is intestinal infection, which is responsible of about 50% of death or severe long-term complication in survivors. If the disease is diagnosed in the chronic stage, we appears other signs and symptoms. Signs and symptoms that are mainly due to portal hypertension, particularly variceal bleed from esophageal, gastric, or anorectal varices, splenomegaly with hypersplenia, which is responsible of low platelet counts, often encountered in the chronic phase of this disease. And in children, this disease is responsible also of growth retardation, delayed sexual characters. In rare cases, we can have also jaundice, portal biliopathy, and ascites. Ascites is much more common in Budd-Chiari syndrome than in EHPBO patients. About etiology, we may divide the risk factors into local and systemic. The most common local risk factors include infections of the abdominal organs like peritonitis, pancreatitis, abdominal infections, inflammatory bowel disease, or biliary tract infections, or in children omphalitis due to incannulation of the umbilical veins during childhood. Among systemic risk factors, cirrhosis and myeloproliferative neoplasm account for the vast majority of causes of EHPBO. Less frequently, causes of disease are thrombophilic risk factors, pregnancy and oral contraceptive use, and autoimmune disease or Behçet disease. In about 20 to 30% of cases, EHBVO have no recognized risk factors. I said that myeloproliferative neoplasm are one of the most common risk factors for EHBVO. This is one study made by our group in cooperation with gastroenterology of our hospital, which included 93 patients with splenic vein thrombosis. And as you can see, JAK2 mutation was discovered in more than 36% of cases. And in the 75 cases where also bone marrow biopsies were available, in more than half of these biopsies, myeloproliferative disorders were diagnosed. So in this kind of disease, JAK2 mutation should be part of the thrombophilia workup, as well as PNH search for PNH clones. What about prognosis? Prognosis depends on the disease that accompanied EHBVO. It's much worse in people with cancer or in people with cirrhosis, and the prognosis is better if without this kind of disease, if in patients with no cancer and no cirrhosis. And what about treatment? We can divide treatment into two steps. The first is medical. We should start as soon as possible anticoagulation therapy. And second step may be also surgical in case medical therapy is insufficient, it doesn't give the expected result. Or in case it's not possible because of the very high risk of bleeding that sometimes patients carry. Medical therapy include anticoagulant, in some rare cases thrombolytic therapy, and very important to start as soon as possible beta blockers in the cases of chronic disease that led to portal hypertension. Endoscopic therapy include ligature of varices to reduce as much as possible the risk of variceal bleeding. And in case medical therapy does not, it's impossible to start or does not give the expected results, shunt surgery would help to reduce the portal hypertension and the complications related to this disease. TIPS is a typical shunt surgery made, which is the transjugular portal shunt, which are mainly portocaval in most cases, but can be also splenorenal or mesocaval. And it's the aim of this treatment is to reduce as much as possible portal hypertension, symptomatic hypersplenics, and incisional growth retardation. In some cases, balloon angioplasty stent placement may be useful, and in very severe conditions unresponsive to medical or surgical treatment, liver transplantation is the only option that remains. Concerning treatment, these are the statements that a group of experts made some years before. They are called Baveno statements. Baveno is a city in northern Italy, where this group of experts meet in 2005 and produced these statements about treatment of EHPDO. They suggest that acute EHPDO rarely resolves spontaneously, and so recanalization, spontaneous recanalization after 6 months is unlikely. That's why, on the basis of current expert opinion, patients with acute EHPDO should be anticoagulated as soon as possible, if possible, for at least 3 months in all patients. Patients with thrombophilia and with EHPDO occurred with an identified precipitating factor that has been removed should continue anticoagulation for at least 6 months. And patients with severe thrombophilia, intestinal infection, without recanalization or recurrent thrombosis should be considered for lifelong treatment with anticoagulants. This study showed some results about anticoagulation. It included almost 100 patients with EHPDO with a median follow-up of 229 days. And after 1 year of anticoagulation, they reported about 44% of relief of portal hypertension, 9% of non-lethal bleeding, only 2 deaths, no related to anticoagulation, 1 for sepsis and 1 for malignancy. So this study encourages doctors to start as soon as possible anticoagulation. There are other therapeutic options in the acute phase, like local or systemic thrombolysis or balloon angioplasty or stent placement. Concerning thrombolysis, there are few case reports in the literature. And as you can see, the result of thrombolysis is not quite encouraging, because only few patients there were a complete recanalization, and most important, there is a high risk of major bleeding. In this study, 2 patients died for gastrointestinal bleeding at septic shock related to bleeding episode. So it can be reserved only in some rare situation, and particularly in patients who present the attention of the doctor in the acute phase. It should not be used when the disease is discovered when it's already chronic, because in this case, the risk of bleeding from varicella is very, very high, and thrombolytic agents should not be used in these patients. Concerning anticoagulant therapy, doctors, on one hand, it should be started as soon as possible, but on the other hand, doctors should face also with the risk of bleeding. So it should be given in a case-by-case basis, balancing risk of bleeding due to bleeding from varices, due to low platelet counts or other comorbidities that increases the risk of bleeding, and risk of recurrence thrombosis due to thrombophilia defects, number of thrombosis, number of veins involved, comorbidities that increase the risk, and percentage of recanalization. So we cannot decide soon always to treat as this patient, but we should differentiate patient by patient on a case-by-case basis. This is a flow chart that we proposed to help doctors in deciding when when anticoagulate patient, if patients should be anticoagulated early or in the late phase. When EHPVO is diagnosed, the first step is consider patient the risk of bleeding of patients. So number of platelets, presence of esophageal varices. And if there is no risk of bleeding, if the risk of bleeding is very low, patient should start anticoagulation as soon as possible, for in a short time or long time, depending on the risk factors that cause the EHPVO. If the risk of bleeding is high, for instance, if platelet counts are less than 50,000, anticoagulation should be avoided or delayed. And if there is esophageal varices, the first step is to treat esophageal varices with endoscopic ligacy. In most cases, this treatment is effective, so patients should then undergo total, complete anticoagulation. In this step, while esophageal varices are treated, we can start with low-dose heparin or half-dose heparin that could help to reduce the burden of thrombus and to wait that varices are completely treated with endoscopy ligacy. And then when the risk of bleeding due to varices is very low, we can start complete and anticoagulation with full dose heparin and oral anticoagulant therapy. Let's talk about Budd-Chiari syndrome now. Budd-Chiari is a name that derived from the name of one doctor and one pathologist who in the middle of 80s of 18th century described for the first time this disease. In 1945, George Budd described for the first time occlusion of the major hepatic veins in a patient with sepsis and alcoholism. And some years later, a German pathologist, Hans Chiari, described obliterated endophlebitis of the small hepatic vein in a patient with syphilis. The prevalence in the Western countries, as I said before, is very rare, much rarer than EHPVO, while it is endemic in some area of Asia, in which it is the first cause of admission for liver disease. In these areas, a pure inferior vena cava block is strongly related with a poor standard of living. It is strongly related with the Budd-Chiari syndrome. While in Western countries, hepatic veins block predominate. And in Asia, inferior vena cava block is the most common cause of Budd-Chiari syndrome. Whatever the geographic area, there is a predominance of females between the patient with pure hepatic vein block, whereas there is an equal number of females and males affected with pure inferior vena cava block. There is an heterogeneous clinical presentation of Budd-Chiari syndrome. From a symptomatic patient, in which this disease is discovered just by chance, to fulminant liver failure cases, in which patients, the only possibility to treat these patients is liver transplantation. The most common complications related to Budd-Chiari syndrome are related to portal hypertension. Ascites is very common, much more common than in EHPVO. and also variceal bleeding and portosystemic encephalopathy. As variance with EHPVO, this disease, bad Chiari syndrome, is related to the high rate of morbidity and mortality if not treated promptly. Concerning the etiology, most of the etiologic factors for EHPVO are present also in patients with bad Chiari syndrome, particularly local abdominal infections, trauma, or caval membranous webs. And in systemic risk factors, myeloproliferative syndromes account also in this case for most cases of bad Chiari syndrome. Cirrhosis at variance is not one common cause. Cirrhosis mainly is the cause of EHPVO. And also in this case, 20 to 30% of cases are idiopathic. And also in this case, because myeloproliferative syndrome are one of the most common causes, JAK2 mutation should be searched, and PNH clone also should be searched. There are no clinical trials for therapy of bad Chiari syndrome. So also now, the therapy is based on expert consensus. Also in this case, the therapy can be both medical and surgical. Usually, we start with medical therapy, first anticoagulation, in some rare cases, thrombolytic therapy, and the use of diuretics to reduce as much as possible the ascites, which is one common complication of bad Chiari syndrome. If medical therapy is not sufficient, surgical therapy can help to reduce portal hypertension, angioplasty with orbital stenting, or shunt surgery, most commonly portocaval tips. If these two treatments are not sufficient, and or in cases the presentation is very severe with fulminant liver failure, the only possibility for patient to survive is liver transplantation. These are studies about thrombolysis in bad Chiari syndrome. As you can see, there is very few case reports, very low rate of success. So it can be confined to very few cases in people with severe presentation, with the aim to give a very rapid recanalization, but the rate of success is very, very low. Anticoagulation improved the outcome since it was introduced in the middle of 1980s. Until now, no anticoagulation-related death is reported so far. So these two facts should stimulate doctors to start as soon as possible anticoagulation in these patients to reduce as much as possible the thrombotic burden and the liver complications. In these studies, this is quite interesting because it is a multi-center study involving 9 European countries in the middle of 2000, with a median follow-up of 17 months, so a quite long follow-up. And among these 163 patients included in this study, 84% had at least one thrombotic risk factor. About half of the patients had 2 or more risk factors. And the most common risk factors, as demonstrated by, is myeloproliferative disorders, which accounted for about half of the patients of this study. Most cases were treated with anticoagulation. About 1/3 were treated with TIPS, and 12% of patients went to liver transplantation because of severe presentation of the disease or unsuccess of the anticoagulation. The good news is that the survival rates of this patient treated appropriately with anticoagulation is quite high, 87% at 1 year and 82% at 2 years. And if you look at the result of the small setting of patients who underwent liver transplantation, these are the results presented by the European Liver Transplantation Association. We can see that the crucial period is the first 3 to 6 months, because mortality related to transplantation is confined almost entirely in the first 3 to 6 months, which are the crucial time. Then the mortality is almost is reduced, and after this crucial period, patients survive almost all. Despite anticoagulants, in this patient, 11 died for recurrence, which is 40% of the cases of patients who underwent liver transplantation, are only 4% of patients in the total number of patients included. And the mortality due to bleeding for anticoagulation is very low. Only 2 patients who underwent liver transplantation. If you look at the total cases, less than 1% of patients had bleeding complications due to oral anticoagulants. The conclusion of this group of experts was that mortality during was almost all confined in the first 3 months after liver transplantation. After 1 year was low, and mainly related to disease recurrence, and mainly confined to patients with strong risk factors of that carry syndrome, like myeloproliferative disorders. One of the main concerns is that the main complications were related in people who had recurrence of venous thrombosis, particularly at the portal vein. So the conclusion of this group of experts is that long-term anticoagulation after liver transplantation is really recommended. And the anticoagulation is mainly performed with vitamin K antagonists with the same range of INR between 2 and 3 as used for all cases of venous thrombosis. Also in this setting, DOACs are used. It seems that they are efficacious and safe. It could be a valid alternative to traditional anticoagulation, low molecular weight heparin and vitamin antagonist. My personal opinion is that we should be careful in selecting patients for this kind of DOACs of anticoagulant treatment, because we know that DOACs are related more than vitamin K antagonists to gastrointestinal bleeding. So the selection of patients may benefit from these newer oral anticoagulants should be very careful. Let's move now to the last part of my presentation, which include upper limb deep vein thrombosis. Upper limb deep vein thrombosis accounts for about 5 to 10% of all venous thrombosis. The incidence is about 2 cases per 100,000 individuals per year. The most common cases are cancer with mediastinal bulky and central catheters. I will not treat this kind of complications because they account for about 2/3 of cases of upper limb deep thrombosis, so they are not quite rare conditions. And I will focus only in the 1/3 of cases of upper limb deep thrombosis, which are so-called idiopathics, not related to cancer with mediastinal bulky or to central venous catheters. Concerning risk factors for idiopathic upper limb deep thrombosis, they are almost the same as other kind of thrombosis. As you can see, the thrombophilia workup in this patient is very similar of that we set up for patients with lower limb deep thrombosis. It includes the free natural anticoagulants, antithrombin protein C, protein S, which account for about 3% of cases. This is the result of our group, or a study of our group. The free anticoagulants, antithrombin protein C and protein S, gave about 5-fold increased risk of upper limb deep thrombosis, and also factor V lead and prothrombin mutation accounted for about a 5- to 6-fold increased risk. Hyperhomocystinemia doesn't seem to be to give an increased risk factors in this setting. Oral contraceptives are a mild risk factor. One important risk factor that should be searched for is related to intense muscular efforts, which is typical of this disease, and is due to pinching of the venous subclavian and axillary venous by the musculoskeletal structure of the thorax, the so-called Paget-Schroeder syndrome. And this is a typical symptom that is that present in people who use their upper limb quite strongly, like, for instance, waterboard players, or people who do canoeing, or who have, make a job in which their upper limb is very, very strongly involved. So in these cases, if people present with these symptoms, we should always suspect upper limb deep thrombosis and make all the appropriate diagnosis of this disease. Also, in this case, we may have interaction between genetic and acquired risk factors. As you can see here, there is the interaction between the two most common genetic risk factors, factor V Leiden or prothrombin mutation, and the use of oral contraceptives, which give a consistent increase in about 14-fold in people who share both risk factors, leading to a synergistic effect between these two risk factors. Let's do some analogies between upper limb and lower limb deep thrombosis. They have the same clinical presentation with swelling, pain, and functional impairment of the arm. A variance of lower limb deep thrombosis, which may lead to pulmonary embolism in about 20 to 30% of cases. Pulmonary embolism is a very rare complication of upper limb deep thrombosis, accounting for no more than 5% of cases. We may have also, in this case, long-term complication with post-thrombotic syndrome in about 1/3 of cases. And the diagnosis is also, in this case, made by duplex ultrasound, or more rarely, venography. And also the treatment is similar. in the acute phase, heparin is used, followed by vitamin K antagonist or DOACs, which are now the common drugs that are used also in this rare condition. There are few studies, or mainly observational studies, on the use of DOACs in these conditions, and all these studies show that they have the similar efficacy and safety than vitamin K antagonists, so we can use them in the place of vitamin K antagonists for long-term treatment. For how long to treat with patients, it depends on the condition that are on the condition that caused this kind of disease. The rate of recurrence is very low; it's about 1%. So, in most cases, we should treat patients for 6 to 12 months and then stop anticoagulation. And the rate of recurrence is very, very low. So in conclusion, what is the take-home messages of this presentation? Venous thrombosis in rare sites or in sites older than the lower limbs are rare but clinically relevant diseases. There should be a high suspicion rate by doctors. So be careful when a patient presents to you with a headache, unexplained and non-responsive to painkillers, or with abdominal pain, which lasts for more days without any explanation. Always suspect this rare condition and send the patient to an appropriate diagnostic workup. Anticoagulants do work and should be treated with as soon as possible. And in people with splenic vein thrombosis, pay attention to liver impairment and risk of bleeding, which should guide you to the appropriate time and to start anticoagulation, and to guide you also with the dosage of anticoagulant use. And thrombophilia screening is warranted. So all these patients should undergo a thrombophilia workup to improve the knowledge about risk factors of the disease, and in people with CVT and splenic vein thrombosis, include in the thrombophilia workup also the JAK2 mutation and the search for clone of PNH. Thank you very much for your attention.
Thank you, sir, for that wonderful presentation. Very comprehensively, you covered this very long subject, and we were crystal clear in your concepts and delivery. We'll give you 2 minutes rest, during which we will just sort out the answer to the quiz that we put to the PG students. So I'll just share my screen and give them the answer, and then come back to you for the question answer session. So the quiz today was related to this picture, in which the incidence of bleeding from various sites were shown graphically, umbilical cord bleeding being the highest, and then going up, muscular and joint bleeding being just about 20%. A lot of you have attempted, and a lot of you are correct also. Factor 13 deficiency is the commonest cause, especially in this part of the world, to do the bleeding in this fashion. And then various kinds of fibrinogen disorders, afibrinogenemia, hypofibrinogenemia, and dysfibrinogenemia. But these are numerically less common than factor 13 deficiency, especially in India. So the correct answer was somewhere around these, factor 13 deficiency and the various sorts of fibrinogen disorders. We received a lot of incorrect answers as well. Everything in the field of bleeding was answered. Von Willebrand, hemophilia, peculiarly thrombophilia, vitamin K deficiency, DIC, use of anticoagulants, liver disorders, thrombocytopenia, and platelet dysfunction were the other answers received. Correct answers received were also by significant number of participants. We received these answers between 11:41. We had just completed the question at 11:40, 11:41 and 11:54. So during a period of about 13 minutes, we got so many answers correct. The first, of course, the fastest finger first will come a little later. Dr. Gunjan Prasad, Dr. Pujitha Reddy, Dr. Gopinathan, Dr. Kamal Patel, Dr. Giri Punja, Dr. Tejaswini, Dr. Akash Khandelwal, Dr. Satarupa, Dr. Archit, Dr. Radhika Shetty, Dr. Navit Tamboli, Dr. Vishwadeep, Dr. Sumit Mir, Dr. Ramesh B, Dr. Varun, Dr. Yoga Lakshmi, Dr. Aishwarya Rai, Dr. Sharifa Mai Sarah, Dr. Krishna Kanan, Dr. Christopher, Dr. Jyoti Save, Dr. Sasita, Dr. Akshaya Mandolai, and Dr. Babita Sodi. All of you, congratulations, your answers were correct. But the winner, the fastest finger fast, is Dr. Rima Miria Abraham. You all know her. She is our discussant today. She's from Department of Hematopathology, AIMS, New Delhi. So Dr. Rima, heartiest congratulations. And we will send you your token of prize on behalf of Mumbai Hematology Group. So that's our answer to the quiz that was asked. Relatively simple, so many correct answers. Now let us go to the question answer session. Dr. Paolo, you can open your video now. Right. So faculty over here, please raise your hands for asking questions. We'll go in the order in which you raise your hand. Meanwhile, I'd like to ask one question. You said for the males, you are more liberal about the duration of anticoagulation. So then how do you generalize? The moment patient is male, you give it long term?
Well, usually, you mean for cerebral venous thrombosis, of course, okay? Usually, if I have a male patient with unprovoked cerebral venous thrombosis, so unexplained, usually I will treat him for long-term anticoagulation because of high rate of recurrence and because I did not find transient risk factors in this case. All the conditions that lead to me to treat for a short time are conditions related to transient risk factors, which are more common in women because they are related to pregnancy, puerperium, or a contraceptive use that can be easily removed or treated with appropriate prophylaxis in case of future pregnancy, for instance.
I think that's a very, very important message because we have not been doing this and we do get recurrences. And when we don't find a cause, we worry and only start long-term anticoagulation after a recurrence. So this is really a lesson. A lot of young people we see with intracranial venous sinus thrombosis and recurrences. Do we know the cause? These idiopathic, so-called idiopathic males getting this?
Why they have a high rate of recurrence? The reason is that the two most common causes of thrombosis for the first episode are female related. So if you leave out these two common causes, that's why women recur very, very rarely. And that men, they don't share this common, which are typical of females. They recur more often.
Thank you.
So for the first episode, the first episode is more common in women. The recurrence is more common in men.
Right. Thank you, sir. Dr. Kunal, go ahead, your question. Let's have one question at a time because I can see a lot of hands up. Yeah.
Yes, sir. My question to you is, how do you manage incidentally detected splenic venous thrombosis? Do you start anticoagulation for each and every case or by case by case?
Well, my study is by case because sometimes we may discover incidentally, this is more common in portal vein thrombosis. There are some children that received at the when they are newborn, they are cannulated with their vein, umbilical vein is cannulated. This is one common cause of portal thrombosis that can be discovered many years later when we have a cover moment. So the decision to treat these patients is not. I cannot. I cannot say that all these patients should be treated indifferently. We should search for other possible risk factors. And if we find very strong risk factors for thrombosis that may also be responsible of recurrence, such as very severe thrombophilic defects or very severe acquired conditions that are associated with higher risk of recurrence, we should treat these patients. In the other cases, if it's only an incidental discover, I don't treat the patient. So the decision is made case by case.
Okay, sir. So we follow them.
Yes, exactly.
Okay. Thank you, sir.
Thank you, Kunal. We will be going to Dr. Gunjan. And before that, we'll take one question from the audience. As the DOACs work very fast, unlike vitamin K antagonists, can that be a replacement for heparin as the starting anticoagulation? In other words, can you start DOAC straight away without any heparin priming?
Okay. If you look at the studies that made the registration of DOACs, there are two DOACs that can be used without heparin. There are rivaroxaban and apixaban. For the other two DOACs, we should have a period of 5 to 7 days before starting DOACs. So 5 to 7 days of heparin. In my opinion, when we treat cerebral vein thrombosis or splenic vein thrombosis, we should always start first with heparin, because the first days of treatment are crucial for the risk of bleeding. And starting directly with DOACs may expose the patient to the high risk of bleeding, especially in the head, which is may be too dangerous. So I suggest always to start with heparin and follow the patient for the first 5 to 7 days, and then decide if I want to use the DOAC. I stop heparin and I start directly with DOACs after having checked that there is no bleeding complication related to the start of anticoagulant therapy.
Fantastic. Thank you. Dr. Gunjan, your question.
Thank you, sir, for a very informative lecture. My question is, should we give anticoagulant prophylaxis in nephrotic syndrome patients to prevent renal vein thrombosis?
In which patients, I'm sorry?
Nephrotic syndrome patients, should we give prophylactic anticoagulation?
Well, nephrotic syndrome is one. I didn't treat it, but it's one of the common cause of thrombosis. We see some rare cases in children with very severe nephrotic syndrome that is quite is a high thrombotic risk, mainly due to very, very low level of antithrombic that they, because antithrombic, they have a very high loss of this protein. In this case, in case of children with this condition, we use heparin and antithrombic concentrate to prevent thrombosis, particularly because they are patients with that need central venous catheters, and if you put these catheters, in a lot of cases they are complicated with thrombosis at the local site. So we give heparin and also antithrombic concentrate to prevent thrombosis. In the adults, it's not usual to use anticoagulants because the nephrotic syndrome in adults is less complicated by venous thrombosis, but you don't use heparin unless they go to some situation where the risk of thrombosis is high, for instance, surgery or immobilization, which are common causes of increased risk of thrombosis. And as usual, in this case, we prophylax depressions.
Thank you. Thank you.
Sir, your voice is breaking. I think you can put off your video, then maybe we can hear you better. Half of it is disappearing. Yeah,
Okay. Yeah, I said that concerning nephrotic syndrome, we usually differentiate between children and adults. In children, nephrotic syndrome is very, very severe, and is quite often complicated by venous thrombosis. That's why we usually start the prophylaxis with heparin together with antithrombic concentrate, because these children, they usually lose antithrombin with urine. We find very, very low levels of antithrombin, 10 to 15%, so quite very, very low level. And they have a high rate of thrombosis, particularly because they need also a catheter, intravenous catheter, that for dialysis and for other kind of treatment. And if you don't prophylax these patients, these catheters quite often are complicated by venous clots. In adults, the situation is different. Usually is not as severe as children, and we treat patients with anticoagulants only when they are complicated by venous thrombosis, or use prophylaxis only in special situations like surgery or immobilization, which are typical situations where the risk of thrombosis is increased, but not, we don't use a generalized prophylaxis in other situations, in olives.
Thank you.
Thank you. Thank you. Thank you, Dr. Gunjan. Dr. Akanksha.
Hello, sir. Very good morning. Thank you for your comprehensive talk. I have a question related to catheter-related thrombosis. So I'd like to ask you if there is any subset of patients where you would test for thrombophilia in those who are having catheter-related thrombosis, like any female patients who are developing thrombosis. Would you test for thrombophilia in any of these patients?
I mean, we perform the thrombophilia workup in all patients with a rare site of thrombosis, especially when it is unexplained. and if it's not explained by common risk factor, for instance, cancer, local cancer, we exclude from thrombophilia workup those with brain cancer, for instance, or cancer in the abdominal organs. Well, the reason of thrombosis is quite explained by cancer itself. So we can avoid thrombophilia workup in this situation, but in all other situations, I suggest to perform this workup.
So if suppose we have a patient who's undergoing a stem cell transplantation and the patient is having thrombocytopenia, but the female subsequently develops thrombosis of the PICC line. So once she recovers, should we go for?
Well, in this particular situation, I think it's useless to thrombophilia screening. It's because the condition of the patient is quite sufficient to explain the thrombosis. So we can avoid, in this case, thrombophilia screening.
Thank you.
Taking the same question ahead, when do you remove the PICC line? When do you give the anticoagulation? And how long do you give the anticoagulation? PICC line related thrombosis.
Thrombosis related to PICC line, usually we treat them for at least 1 month after removal. Then we check with ultrasound if the thrombus disappeared, which is the most common of cases. We stop anticoagulation. So we decide to anticoagulate for 1 month after removal and then stop.
And do you ever remove the PICC line?
If the PICC line cannot be used because of the thrombosis, we removed it because it's a possible trigger of thrombosis and also infections. So if it works, we leave the PICC line and we treat with anticoagulants patients. If it doesn't work, we remove it.
Thank you. Dr. Shilpa.
Thank you, sir. Sir, my question is, in cases of travel-related thrombosis, do we still have to evaluate for thrombophilia? Because travel is one of the risk factor, imminent risk factor. However, their guidelines are quite kind of contradictory, where some of them do say that travel-associated may need evaluation.
Okay. Well, first of all, we should specify which travel, because travel is a recognized risk factor only for a long-haul travel, more than 4 hours, for instance. We usually do thrombophilia screening because we are interested in searching for this kind of defects. So usually I suggest you maybe you can search for the most common defects, for instance, factor V protein mutation, and confine the thrombophilia screening also only to these defects. And my suggestion is also to to look at the history of patient and to of positive family history and or a pet is useful. So I say yes, confine to the most common risk factors, and look also at the family history. That's very important. It's very important because the same defects may have a different patterns of penetrance.
Thank you, sir.
So there are also the family, and that's quite important in the management of patients also.
Sir, do you want to log out and log in again? Because a lot of words we are not able to hear.
Okay.
Yeah.
Okay.
Lecture went very smooth, but this is getting broken.
Can you see me now? Yes.
Yeah, we can hear you. Yes.
Okay.
All right. So next, Dr. Rima.
Good morning, sir. So my question was regarding coronary sinus thrombosis. Can it happen spontaneously, and how will we differentiate it from arterial MI? And is the management different?
Do you mean which kind of thrombosis?
Coronary sinus thrombosis, sir?
Rima, repeat.
So coronary sinus thrombosis, can it happen spontaneously? Can we differentiate it from arterial MI, and how different is the management?
Coronary sinus thrombosis, spontaneously, and differentiation from coronary artery thrombosis.
Well, we didn't see too much in this condition, so I cannot answer your question. So
it's probably very rare.
Sorry.
Yeah. Thank you.
It's
Dr.
very
Radhika.
rare.
Yeah, fine. Dr. Radhika. Yeah.
Thank you, sir, for the beautiful presentation. My question is regarding renal vein thrombosis, retinal vein thrombosis. So there are some anticoagulation forums who opine that thrombophilia workup and anticoagulation therapy are not routinely recommended in retinal vein thrombosis. However, there is a meta-analysis which suggests low molecular weight heparin for a period of 1 to 3 months in a retinal vein thrombosis. Can you throw some light on management of retinal vein thrombosis, sir?
Retinal vein thrombosis is can be treated apart from other kind of thrombosis, because in our experience we didn't find the common cause of genetic or acquired cause of venous thrombosis are not found in retinal vein thrombosis, which is mainly due to local factors. And also for the treatment, it's true that there is one meta-analysis that suggests the use of low molecular weight heparin in the first month from diagnosis. But in our experience, any kind of anticoagulation didn't help to reduce the rate of recurrence. We started anticoagulation in some patients also for many months, but we didn't have results in this sense. So unless you have a patient with diagnosis of retinal vein thrombosis, and you can start anticoagulation in a very early phase, but then I don't suggest to prolong anticoagulation because you don't have benefit. And the main benefit are related to the local treatment with anti-VEGF that reduce the edema which is the main complication of this retinal vein thrombosis. One suggestion is also to search for systemic cardiovascular risk factors, because sometimes retinal vein thrombosis is the first appearance of subsequent cardiovascular events. So search for cardiovascular risk factors, traditional cardiovascular risk factors, and manage them.
Thrombophilia workup, sir? Do you recommend thrombophilia workup?
Only in young patients, not in old patients.
Thank you, sir. Thank you very much.
Thank you, Dr. Radhika. And Dr. Priyanka.
Yes, thank you, sir. Thank you for the presentation. I have two questions. First is related when we have a patient of a cerebral or a cranial thrombosis, intracranial thrombosis. In those cases, we see sometimes that there is hemorrhagic transformation. As you said that initially we start with a low dose heparin in those cases, wait for some time whether the hemorrhage is increasing or not, and then you go for a full dose therapeutic anticoagulation. So what is your suggestion regarding when to repeat this imaging to see whether the intracranial hemorrhage is further enlarging or it has stabilized?
Well, my suggestion was that you should start as soon as possible anticoagulation, because in many cases, the hemorrhagic complication is subsequent of thrombosis. So if you don't treat thrombosis, you may have a worsened hemorrhagic complication. The only situation where you may pay attention is when the hemorrhagic lesion is very large at presentation. In this case, you should be cautious to start with low dose heparin and repeat several times the imaging to see the evolution of this hemorrhage. In case of worsen the hemorrhagic lesion, you should, of course, reduce or stop for a few days the anticoagulation, because of course you cannot further worsen this fatal complication. But in my experience, this happened quite rarely. In most cases, the hemorrhagic lesions disappears or improve when you start anticoagulation, because it's very important to improve the blood flow into the veins as soon as possible.
Sir, my query was, when after starting the heparin, when do we repeat an imaging to see the status of the hemorrhagic transformation? After 24 hours or after 72 hours, whether there is a definite time period when I should repeat it, if the hemorrhage is large enough?
Okay, so when they present after treatment, you see? Also, if I start with full dose heparin, I reduce the dose and I follow the patients until the hemorrhagic lesion becomes stable or is reducing.
Okay. And sir, the second question was regarding like if there is a provoked thrombosis, then we know that since there is a provoking factor, we anticoagulate for 3 months and then we stop. So at 3 months, do we repeat a D-dimer and an imaging to see the level of the recanalization? And if the recanalization is still not done, because we know by 3 months, the recanalization, whatever the status will be, it will remain like that. Even if we increase, even if we continue with it, it is not going to further recanalize more. So should we monitor it or should we continue? We stop it right at that moment?
Of course, yes. Definitely, yes. You should always have pictures of what happened after 3 to 6 months of treatment. If you don't find a complete recanalization, you may continue anticoagulation. But then my suggestion, in some cases, you have still after 6 to 12 months a residual thrombosis. If you don't have any further improvement, you may stop anticoagulation and leave the residual thrombus, because in this case, if the risk factor is removed, is the transient is removed, the probability that even in the absence of complete recanalization, the probability that the thrombosis recurs is very, very low. But of course, you should have always a picture of what is the result of your anticoagulation, which is very important to compare in case of in case the patient presents to you with other symptoms later on. And then you have to compare the newest imaging with the one that you performed before stopping anticoagulation to see if there is a true recurrence or not. It's always important for all kinds of thrombosis, also for the lower limb venous thrombosis or pulmonary embolism.
Okay. Thank you, sir.
And she had asked one more part of the question. Is D-dimer important in making decisions?
No, not important. Not important because especially, for instance, for splenic venous thrombosis or if you are in some conditions where the dimer may be high independently on thrombosis. So in most cases, the dimer is confusing. So you don't do this test to decide to stop or not anticoagulation.
Thank you so much. Doctor.
Thank you, sir. Thank you, sir.
Thank you, Priyanka. Dr. Akshay.
Thank you, sir. And thank you, sir, for the informative talk. Sir, I would like to ask that how would you manage venous thrombosis in a child of TLL presenting with superior vena cava syndrome?
Okay. T-cell acute lymphoblastic leukemia, child having superior vena cava thrombosis.
So in this case, I should pay attention at platelet counts of patients because these are very important information to decide whether or not to use full dose anticoagulation. Of course, I will, if possible, anticoagulate the patient with low molecular weight heparin, and I will continue this kind of treatment because it's very easy to manage patients in case of worsening conditions that increase the risk of bleeding due to low level of platelets secondary to chemotherapy. So I will not start oral anticoagulation, but I will manage also with low molecular weight heparin with varying the doses on the basis of the condition of the patients after chemotherapy.
Thank you, sir.
Thank you, Dr. Akshay. Dr. Ankit, you had raised hand. You have a question?
Yeah. Good morning, sir. Thank you for that wonderful lecture. I have a couple of questions. In a patient who has a non-alcoholic liver disease and has chronic liver disease with portal hypertension and develops portal vein thrombosis, and the liver dysfunction is already existing, which is causing a coagulopathy problem with it. So in thrombosis of such kind, how do we treat and what would be your anticoagulant of choice?
Well, if the liver disease is quite extended, of course, we have two order of problems. The first one is how to start anticoagulation. And in this case, you should remember that the liver disease does not only reduce procoagulant factors, but also anticoagulant factors. So in most cases, the patient has a balance of this anticoagulation, and having a prothrombin time or a PTT prolonged is not a condition that should prompt you to avoid anticoagulation, because in most cases, patient, even when his procoagulant factors low, he develops thrombosis because there is an imbalance of all the pattern of coagulation. So I start anticoagulation with heparin. The problem when I use oral anticoagulation, oral vitamin K antagonist, is that which is the range that should I take the patients. Because if we start with a prothrombin time is already prolonged, I don't know what if the correct INR should be between 2 and 3, for instance, but we don't have any possibility to make other kind of to change our our possibility to treat the patients. We may maybe perform such complicated tests as thrombin generation test that may guide us to the degree of, but they are very complicated and very expensive, and not all centers can be performed. So I suggest just to treat patient as usual with taking the INR between 2 and 3, even when the starting level of thrombin time is high, and monitor the patient clinically.
Can we treat them on the lines of APLA? Like even in patients with APLA, we do face the similar problems with the INR being out of range when they have antibodies against the factors as well. And they also have the risk of thrombosis.
Okay, patient with
APL syndrome, lupus.
Antiphospholipid syndrome.
Yeah.
Yes, that would be a problem for the management of heparin treatment. But if you use low molecular weight heparin at usual doses, you don't have to monitor. Or the other possibility is to use anti-10A activity of the heparin. But usually in patients with without renal impairment, classical doses of low molecular weight heparin are enough and should not be monitored with any kind of coagulation tests.
So I have one patient who is splanchnic with thrombosis, splenic as well as portal. He's around 50 years, previously just hypertensive. I have done his PNH workup, which is negative. I have done his marrow. There is some evidence of myeloid proliferation. His hemoglobin is in the range of 15.1, that is 151 gram per liter. And his WBC count is in the range of 10 to 12,000. Platelets are in the range of 3.5 to 5 lakhs. There's no hepatosplenomegaly. And all his MPN panel is negative, PNH workup is negative, APLA workup is negative. Now he's almost completing 6 months of therapy. So do we need to do any other tests, or can we stop his anticoagulation if there is, there is some residual which is there in his last Doppler, which I've done last week. So how long to continue? And
well, in this case, if I didn't find any classical risk factors that explain the thrombosis, I will treat the patient for at least 6 to 12 months. And then if I don't find any other possible causes that explain the thrombosis, I stop anticoagulation and I follow the patients with Doppler ultrasound in the subsequent months after stopping anticoagulation.
But we have to do the entire workup, which I've done. That was justifiable that we do the marrow, we do the MPN workup and the PNH workup, because he didn't have any underlying.
Yes, we should do this before. I suggest to do also the JAK2 mutation search and PNH search,
so
even if the blood count is normal. Because sometimes the first clinical appearance of a myeloproliferated neoplasm is the thrombosis. And then the disease occurs later on. In time.
So
I suggest to do always.
I had done this, but I just wanted to know whether this was justifiable. We do it as a part of protocol because we have seen such cases. One more last question, sir. I have a patient who is a 30-year-old lady. She was on infertility therapy with hormonal stimulants and then developed a cortical sinus thrombosis. She is on rivaroxaban now, but she wants to again go back to the IVF therapy. So how and when can we restart that? And do we follow the same as we follow in pregnancy-related thrombosis to switch her to low molecular weight heparin as a preconception?
Yes, if thrombosis is caused by hormonal treatment, pregnancies should be prophylaxed with heparin for all the pregnancy because they're a high risk of recurrence during pregnancy and puerperium also. If the patient wants to continue or restart hormonal treatment, you can do it safely, maintaining anticoagulant treatment. Because it's demonstrated that during anticoagulant treatment, if you restart or hormonal treatment, the risk of recurrence is almost null. Okay, so the patient is protected by anticoagulant, and during pregnancy, she should be received prophylaxis. Of course, yes.
But she was requesting for some oral thing because giving her injections for so long.
Yeah, I know, but
well,
yes, we know that we cannot give this drug. The DOACs are forbidden in pregnancy. We have some experience in patients with prosthetic heart valves, during which we treat them with heparin for the first 3 months. Then we restart AVK from the 4th to the last month of pregnancy, and then we stop again VKA and restart heparin. So we can do, if we don't want to inject to use the injection for all the 9 months of pregnancy, that could be a possible solution. But usually women are quite collaborative in this sense. If you motivate them, they don't care.
So that is why she was like, that is also a complicated thing, which hormonal stimulants, beta HCG going high. So, okay. Thank you, sir.
Yeah, thank you.
Thank you, Dr. Aniket. Just one question related to that. If a woman on oral contraceptive pill develops a cortical venous thrombosis, then she should be given oral contraceptive pills in future under cover of anticoagulation, or it should be a total no for
her? She can use oral contraceptives by continuing anticoagulation. She can use oral contraceptives, continue anticoagulation. It's safe. It's a safe approach. It is demonstrated that during anticoagulation, the risk of recurrence is very, very low.
And that can be DOAC also?
Yes.
It can be. Yeah.
Yes.
Thank you. And another question which Aniket asked about JAK2. Is it only JAK2 that is important, or even CALR and MPL mutations? Do they also cause thrombosis?
Well, we can extend the classical JAK2, the exon 12, and the CALR. Yes. CALR, yes.
They are equally thrombogenic.
Yes.
So all of them are
less than the classical JAK2 mutation.
And those patients whom you pick up at the level of JAK2 positivity with normal hemoglobin WBC platelet, you will be subsequently treating their myeloproliferative neoplasm with a specific drug, ruxolitinib, etc. So can you stop the anticoagulation after a while?
No, I prefer to continue because, yes, because JAK2 mutation is a known risk factor for thrombosis, independently on the presence or not of the myeloproliferative neoplasm. So this is one condition that in which I suggest to continue anticoagulation.
Thank you. Dr. Radhika, another question from you.
Yes, my question is COVID vaccine associated thrombosis. How long, what should be the duration of anticoagulation? Any preferred anticoagulation of choice here?
For which condition? I mean,
COVID vaccine.
COVID vaccine.
COVID vaccine.
COVID vaccine. Oh, Okay.
What should be the duration of anticoagulation? Any preferred?
Usually, it's a short duration. I treat patients with 3 to 6 months, depending on the type of thrombosis, and then I will stop anticoagulation.
Any preferred choice of anticoagulation, sir?
DOACs are a good choice.
DOACs. Okay.
DOACs, yes.
Another question from you? No.
No, sir.
Okay.
Thank you, sir.
Priyanka?
Sir, just a continuation regarding a patient who is on oral contraceptive pill and developed a deep vein thrombosis. Patient started on oral anticoagulants. Patient started preferred for a DOAC. And the OC pill was given not for contraception, but for her irregular or heavy menses. So patient, whenever the patient was having her cycles again, because the OC pills were stopped and she was on this rivaroxaban, patient's menstrual cycles were again heavy. So when I had advised for taking tranexamic acid during that time, patient herself is a gynecologist. So she had stopped taking Tranexa thinking that it will again aggravate her thrombosis. And for that, she has discontinued the rivaroxaban. So how do you counsel these patients?
Well, one possibility is to change DOACs, because not all DOACs gave the same hemorrhagic problems in this case. I know, for instance, rivaroxaban and the doxaban also are accompanied by a higher risk of bleeding than, for instance, apixaban. Another possibility is to use, if possible, a DOAC at the low dose. If the time between the start of thrombosis and it's quite long enough, you can reduce the dose of the DOACs. With apixaban, you can do it, because there are studies with also with the low dose. The other possibility is to shift to vitamin K antagonists, which are associated with less mucosal bleeding than DOACs. But first of all, I will change the DOAC, try to reduce the dose if possible, and then later on change type of anticoagulation, shifting from DOACs to via VKA.
So no role of tranexamic acid over here?
We use this for a short period during anticoagulation. If you use Tranex during anticoagulation, there's no problem. The problem is when you use it stopping anticoagulation. That can increase the risk of thrombus. But if you use this during anticoagulation, it's safe.
And sir, another question is, if a patient is on, suppose, dabigatran, and he has recurrent thrombosis, would you like to change it to another DOAC like a rivaroxaban, like an anti-10A inhibitor, or would you like to prefer vitamin K antagonist for these patients? Because vitamin K antagonist, you need to monitor an INR. Patient is far off. He does not have the means to have regular monitoring of the INR.
First of all, I will check the compliance of the patient, and we'll check, if possible, the level of anticoagulation during the dabigatran. Because if there is a recurrence of thrombosis, it's important to see if levels of concentration of the DOACs is normal, or at least it's not low. Okay, you don't know a real therapeutic range, but if you find very low levels of this DOAC, it may be that it may be possible that the complication, the traumatic complication, is due to inefficacy of this DOAC. There are no studies that can guide us in this sense. So changing from one DOAC to another DOAC is a good choice. it's one possibility, but in my opinion, it could be that is the failure of the door by itself, not the type of door, the possibility. So the other possibility is to move to VKA therapy. It also depends on the what you are treating. Are you treating maybe so atrial fibrillation in patients with severe cardiac the cardiac anatomy that is prompt to form thrombosis, for instance, people with myocardial dilated myocardiopathy, that is a condition with a high risk of thrombosis, in which we also saw a lot of thrombotic complications during DOACs, but not during VKA. So it's important also to check other factors that may have explained the failure of the DOAC.
And sir, last
and
question.
Also,
can
exclude also antiphospholipid antibodies,
yes,
which is one condition that it's known in which the
PK.
DOAC are not good.
Yes, sir. Sir, another last question can I ask? Sir, hyperhomocystinemia, we find patients of hyperhomocystinemia sometimes associated with B12 deficiency, sometimes they are isolated, not associated with B12 deficiency. So is there a difference in approach for these patients?
Well, usually we treat hyperhomocystinemia with vitamin complex independently on the vitamin level. Of course, if you find a particular vitamin level, you treat this one. If you find, for instance, a low level of folate, you just give only folate. But if your vitamin levels are normal, we can use still an amount of vitamins that improve the level of homocysteine in most of cases.
Thank you, sir. Thank you so much.
Yeah.
Thank you. Can we take some questions from the audience for the next 5-10 minutes? Is it okay? You have another 5-10 minutes, sir?
Okay.
Yeah. I will only ask those questions which are not covered. So some of the questions are related to, do you have a preference for a particular DOAC? Is one DOAC better than other? Is apixaban better than others? That is the question.
Well, usually when I treat venous thrombosis, I always ask myself whether these patients will benefit from long-term anticoagulation or not. So in this case, I will choose those DOACs for which there are studies with a reduction dose after the acute phase, which are apixaban and rivaroxaban, which are the only two drugs for which we have studies on the use of reduction of low doses after the first 6 months of treatment for the acute phase. Then, of course, I will look at renal function, and I choose the and I also take a look at patient care, because if I treat patients, this is typical of all patients who have a caregiver. I always ask if the caregiver can help the patient in giving the drug. So if the caregiver is present for all day, I don't have preferences, but it is present only in the first part of the day, only in the morning, only in the afternoon. I will prefer the DOAC with one administration per day because I'm sure that this drug will be given to the patient with the DOACs with 2 administration per day. Maybe one of these tablets will not be taken by the patients. So that's one condition that we should also look at the care system, all the surrounding of the patients. The patient is able to take the drug by itself, or it needs help, and that's important to choose between a single dose or twice dose per day.
Quite right. So there are some questions related to indications of thrombolysis or thrombectomy in venous thrombosis.
Or this usually is the thrombolysis and thrombectomy are rarely useful. It should be confined to very complicated cases in which we need rapid improvement of the blood flow. But this is very, very rare, especially in thrombosis at the rare sites, sinus venous or splenic vein thrombosis, where this kind of management is complicated by quite high rate of hemorrhages with a very high case fatality rate. So I don't suggest to use this treatment quite often, but only confined to very, very, very rare conditions. Very rare and complicated conditions.
Right, sir. There's few questions related to use of antithrombotic stockings. Are they useful in the DVT of leg? Stockings are useful?
Yeah, are very useful for DVT at the lower leg, because they may improve the long-term complication, which is the post-Levickis syndrome. The use of the constant use of elastic stockings may prevent these quite frequent complications, which is not severe, but I mean, it's quite life. It worsens the life of patients, because it's quite patients suffer from this condition. So I suggest the constant use, especially in the first years after thrombosis.
Thank you, sir. Those are all the questions we have from the audience. Many of them are already answered, so I'm not putting them again to you. May I request all the Indian faculty to open their videos and join me in thanking Dr. Paolo.
Thank you
just as a
for
gesture.
inviting me. It was a very, really nice experience, and I congratulate your group, because they are very, very interested in this field, and
we have very, very fantastic bunch of young hematologists.
Yes.
Very dynamic, very highly knowledgeable, and their questions are so fantastic.
And also very curious. It is very important to be curious in life, because curiosity is one of the main thing that stimulate research. If you're not curious, research will stop. So always ask questions and try to give an answer.
That's very well said. So thank you, sir, Dr. Paolo, Dr. Ganju, our chief guest, all the discussants this afternoon, 2 or 3 hours of Sunday afternoon for academics. That's fantastic. So thank you, sir.
Thank you.
To all of you.
Thank you very much.
Bye-bye.
You're welcome. Bye-bye.
Bye, sir.
Bye.